We shall now move on to pediatric rehab on a panel discussion on cerebral palsy, and may I kindly invite Dr. Rezwana Parvin to conduct the proceedings.
Good afternoon, everyone. I know after lunch everyone is having dumping syndrome, but still try to concentrate. Today's panel discussion is on cerebral palsy. May I invite on stage Dr. Sanjukta De, Consultant Pediatrician, Peerless Hospital, Kolkata. Dr. Prabir Kumar Mondol, Head of the Department of PMR, MR Bangur Hospital, Kolkata. Dr. Shubhajit Chakraborty, Assistant Professor, Department of PMR, SB Nittar, Odisha. And Dr. Saurabh Dev, SR, Department of PMR, Bardhaman Medical College and Hospital. The first question is to ma'am. What is cerebral palsy and its incidence in India?
Good afternoon, everybody, and thank you for having me at this session. The very first question, as I told Rezwana, sounds like I'm giving a viva voce. But cerebral palsy definition, classically, when we read our FORFER, it was static encephalopathy. So what we are understanding by cerebral palsy, it's a non-progressive motor dysfunction, primarily affecting the brain that was immature, and it will happen either prenatally, antenatally, intranatally, or postnatally, soon after birth. So this is what we mean by cerebral palsy. And looking up the incidence, I saw that worldwide it is between 2 to 3 per 1,000 live births. And in India too, it's approximately the same, but there is some rural and urban variations.
Okay, ma'am. Thank you, ma'am. Next question to Dr. P. Mondol, sir. What are the types of cerebral palsy?
Cerebral palsy is clinically 4 types. That is spastic, that is due to involvement of cortex, dyskinetic due to involvement of basal ganglia, atonic due to involvement of cerebellum, and mixed variety. But anatomically, we can divide it in hemiplegic, that is monoplegic, diplegic, quadriplegic, and double hemiplegic.
Okay, thank you, sir. Next question is to ma'am. Repeat. What are the etiologies of cerebral palsy?
Again, talking of etiology, just as I said, it is an insult to the growing brain. So the etiology is mostly birth related. So low birth weight, prematurity, maternal problems like infections and diabetes, hypertension, these are risk factors. Early delivery and low birth weight, twinning remain one of the greatest risk factors. Good obstetric care. And obviously there might be other genetic factors sometimes involved, but that is very complicated because now in pediatrics we are realizing that many of the genetic disorders that were first some things that we were thinking it to be CP were actually genetic disorders. So that is another very gray area. These are the usual etiologies, infections and intranatal or antenatal, postnatal, birth history, and also postnatally it could be traumatic brain injury as well. Early on in life when the brain has not matured fully could lead to cerebral palsy. Meningitis also early on in life. All these incidences are going down due to vaccinations and better obstetric care. And when we talk of etiology, we should also talk of prevention. So our obstetric colleagues are doing magnificent job in a way that now according to Gynecology Society guidelines, they give steroids to all premature and low birth weight expected deliveries, and use of magnesium sulfate also to prevent early delivery. That is also helping. But again, IVF is going up, twinnings are going up, multiple pregnancies are going up, but better obstetric care and better neonatal care, these are what could decrease the incidence of CP as well.
Next question is to Dr. S. Chakraborty. What are the common complications of cerebral palsy?
Actually, as ma'am said, that cerebral palsy is yet to find out the exact cause. What is the cause? So it is multifactorial, you can say, but outcome is almost the same. That is, it's a non-progressive growth disorder, but it is not progressing. But the main part of what is affecting in the CP is this motor function first. So whenever there is a function of affecting the motor function, so there will be delayed developmental delay as well in the pediatric for age group wise. This is the complication and this is the symptom, it is first manifesting as well. As well as when there is a delayed motor function, there is a loss of other problem that patient cannot swallow properly. So if they cannot swallow, there is a chance of recurrent lung infection that can be treated as one of the complications. There will be the oral hygiene, poor oral hygiene that can cause dental caries, delayed cognitive function, delayed developmental milestone achievements. These are all comes as a complications. When it is not, you cannot say that particularly which type of CP is and what is the grade of the CP. On the basis of that, the complication varies. So initially, you can say that it is mainly the complication is the motor function as well as cognitive function, both as a comes as a whole complex the complication part.
Can I make a comment on that? So, as we said, it's a motor function problem. Along with that, there is in some situations we have problems with cognitive functions. When many of them have issues with speech, with hearing, bladder and bowel disorders, intellectual disorders, all of that then will lead to the complications, including many of them 10 to 20% having seizures.
Seizures, epilepsy, seizure is also the another complication.
That is in the rehab process, that is so very important, because when the nutrition is a major issue, because many of them will have swallowing problems.
Swallowing difficulties, so there is a chance of always the nutrition is
aspiration
and recurrent lung infection is the most common thing in the CP child, and bladder incontinence is another complication.
And bladder bowel still for pediatric patients easy to handle. In a way, you put them in a diaper and forget about it. But what about the nutrition? Because the mother is struggling every day to feed the baby, and there is also the constant aspiration, and they will come to our OPD and say, my child feeds, the child is feeding well, and I said, please feed the child, and then they are just lying the patient flat on the bed and using a jhinuk or a spoon and pouring it down, and the child starts gargling. When it stops gargling and stops, the mother thinks the swallowing. So part of it is going to the lungs, part is staying in the stomach. So this is a chronic aspiration pneumonia and poor, poor weight gain. And also they feel, and this is something that we have been able to percolate as pediatricians, and we need to percolate more, is that cerebral palsy patients need vaccination as much as other children do. So many of them, when they go to the local health centers, they said, oh, they have cerebral palsy or they have epilepsy, so they cannot be vaccinated. So these are also very important things that lead to complications.
Misconceptions among the caregiver that whether they will be vaccinated or not.
Yes.
It's the biggest misconceptions.
Thank you, ma'am. Next question is to P. Mondal, sir. Basic management protocol of cerebral palsy.
The management protocol should be divided in different as per different age group. We can divide the CP child in the infant, in childhood period, in preschool period, and adulthood. In early childhood, that is in infant period, the early soft sign of CP should be diagnosed. Suppose there is problem of feeding, there is problem of handling the child. Sometimes it is very floppy baby, sometimes it is very spastic baby, rigid baby. There is difficulty in different primitive reflexes, they are persisting more than 3 months. And there is a problem in that is persistent of these primitive reflexes that dictate that this child may become CP child. After 1 year, there should be management protocol, and in this period, we should go for neurofacilitation technique, like in the European country, they go for Borgia technique, and in Western country, B-Bobath technique of neurofacilitation in the infant period. After that, after 1 year, we should go for more towards the patient should be in erect positioning of the patient, and also exercise to reduce the spasticity and to improve the antagonistic muscle power, and also reduce the spasticity with exercise and positioning of the child. After that, in preschool period, we should go for more intensive exercises along with try to socialize the child with other person, his environment, everything should be take care. And along with this, in this period, we should train the mother and the caregiver. What is the problem of this child, this CP child? What should their purpose? They don't know how to handle the child. What is the ultimate result? They want to know what is the fate of this child. We should explain everything to mother, parent, and the caregivers. At preschool period, we should go for surgery to make the deformity and to treat the deformity and also to reduce the spasticity and other things. The planning should be in this way, and the child should be in a position that they can spend many times with playing. So, in effective functional movement of the body should be encouraged. Okay. These are the protocol for treatment and management of the body.
Okay, sir. Next question is to Dr. Saurabh. What are the poor prognostic factors for rehabilitation?
Thank you, Rezwana, for asking this question. This is more clinical and practical question, I think, because when a baby diagnosed with CP is coming to our OP or IP, they will come with their parent. So the parent is asking us what is the prognosis and what will be the result for the therapy we are giving. So if we know the prognosis, good prognostic factor or bad prognostic factor, then we can counsel the patient very thoroughly. Among the poor prognostic factor, the most important is the severity of the gross motor function, because we know the GMFC scale is that 1 to 5 is there. They are 4 and 5. They have very poor prognostic factor for the rehabilitation purpose. Number 2, if there is some delayed milestone, some consensus they are saying that if a baby can't sit independently by 2 years, there is very less chance to walk independently. Number 3, some study they are saying that intellectual disability. So if patient has some intellectual disability, so he can't respond properly with the therapy what we are providing the patient. And sometimes the seizure, this is very important. Recurrent seizure is a poor prognostic factor, and that will hinder the neuroplasticity basically. Basically we had already mentioned what therapy we are giving, that basically generate the neuroplasticity, improve the muscle tone. If recurrent seizure will come, and that will destroy everything. And one more thing is some visual problem is there. There will be visual problem, then patient will have some problem in balancing, coordination. Okay.
I like to add something. Hemiplegic and diplegic CP had good prognosis, but there is quadriplegia that will be very difficult to manage, and ultimately their health deteriorate due to nutritional problem and the infection, any other things. So we can predict the outcome of CP in case of diplegia and hemiplegia, not in other cases.
Can I just ask just a quick point, because all PMR people are here. So getting the pediatric, the children come to us first. First of all, during vaccination, when we are giving the vaccine, we have a certain situations where we have these red flags, too tight muscles, adductor spasms, scissoring, hypotonia, irritable child, mother is also complaining, have certain complaints, HIE. So we are responsible for sending the patients to you. And if we fail there and if we delay, then we have lost the chance to rehabilitate the child well. And I'm telling you, you are talking of prognostic factors for rehabilitation once a patient reaches the department. I think in our country, the main important factor for bad rehabilitation is picking up the problem late, the parents not accepting the situation and not visiting the correct PMR facility. Sometimes they say we have somebody in locality who comes and does malish and goes away. And I said PMR rehabilitation is not massage therapy. You need to be in the right place for the right things. So, and another thing is parental, societal issues, their understanding, their literacy, their financial situation are all prognostic factors. Because without that, they will not follow up. They will not even go to you. That's the problem.
Sure,
Even
ma'am,
first time the diagnosis of whether the child is suffering from CP or anything, that is also being delayed. Because fast patients come to the pediatricians and they come to the delayed developmental milestone. Mother always complains, okay, ওর বাচ্চাটা দাঁড়াতে পারছে, আমার বাচ্চাটা কেন পারছে না। তো এখান থেকে শুরু হয়। So initial phase 2-3 বছর it is very difficult to diagnose whether this child is suffering from CP or not. হ্যাঁ, যদি তার ischemic encephalopathy হয়ে থাকে, that is a diagnosis. Franks, then you can identify. But minor cases, diagnosis becomes very late. And when the diagnosis is late, then already deformity starts. So, এই সময় পেশেন্টগুলো when the patient is coming to us, this type of group of patient, when the delayed diagnosis, and they are hardly going to any rehabilitation specialist. They are mainly seeking to the pediatricians, and pediatricians in India are not that much available. Sometimes they are called a general practitioner giving some medication, some are referring to the orthopedic. So this is the patient that's just loitering here and there, and ultimately they are when they're reaching to the proper service provider, it becomes delayed. Yes.
So, next question is to Dr. S. Chakraborty sir. Elaborate the different types of gait in CP.
Gait in CP. Okay, CP, mainly the CP has I will just differentiate two types of gaits first. One is the ataxic gait and the atatoid gait. So these are the different things of which part of brain is affected. This is another thing. And when are coming to the plastic gaits, and there are different classifications. So first classification, Rod-Graham classification is widely globally accepted. There are mainly the 5 stages. First is equinus, means you know that it is a horse kind of standing gait. So straight, knee extended, hip extended, and or normal extended, and the foot is equinus. That is a plantar gait. And then is the pseudo-equinus. Then there is a pseudo-equinus, means then foot is neutral positions, but other things are little bit flexed, and that's giving the appearance of the equinus thing. So another gait is a jumping gait. You can say it is a flexion type of gait, but foot is again in the equinus. And crouch gait is just reverse of this equinus. That is the instead of the plantar gait is the rossiflexions. And another gait can be the combination of these two. So basically the 5 classification of gaits and the Graham stores. And besides that, there is a upper metacardial lesions when happening. There is a ataxic gait can have the atatoid gait is happening. Especially when this is the basal ganglia is affecting, there is chances the atatoid kind of gait, and when the cerebellum is affecting, there is ataxic kind of gaits. And a combination of gait you can have, and on a gait is a scissoring gait can also happen. And when it's a hemiplegic CP, there is sometimes the circumduction is taking place. So there is a multiple kind of gaits you can get, but main thing is that basically classical gaits in the CP, when you are dealing with this, especially the patient's GMFC 2 or 3 classifications, in that case, we are encountering mainly the equinus type of gait and crouch type of gait. Mainly we are dealing with this, and mainly surgical they are sort of much better explain.
Okay, thank you. Next question is to Dr. P. Mondal sir. What is spasticity and elaborate its management?
Spasticity is velocity dependent increased tone of the muscle. So usually spasticity we measure with the modified Ashworth scale, Tardieu scale, and electrophysiological measurement also. By seeing the H reflex we can measure it. It is due to inhibition of the spinal reflex by the cortex. That is, cortex is involved. That's why the uninhibited reflex become the spasticity, make the spasticity. So the management protocol should be to perform activities, that is to walk better, to reduce the spasticity, to maintain the hygiene. This should be the goal. And the treatment protocol should be, in case of physiotherapy, this is positioning and the stretching and strengthening of the muscles. There should be some treatment in medical treatment with baclofen, diazepam, tizanidine we can use, and after that, if the spasticity hamper in the growth of the bone, we can go for surgical intervention at the age of 5 to 7 years, at least preschool stage. And also there is provision of selective rhizotomy to prevent the spasticity. Though the result of this rhizotomy is not yet proved that is good enough. So these are the practice we can do.
Okay. Next question is to Dr. Shourabh. Elaborate the surgeries effective in spastic CP.
Exactly, this topic is huge for me to elaborate the surgeries effective in spastic CP. There is a lot of deformity. We are
Running out of time. So in short.
I will explain very shortly. When a patient is coming to us with a deformity with CP like hemiplegia or diplegia, first we have to assess the patient, and very shortly we should do 4 or 5 basic examinations like Thomas test to check the hip flexion deformity, popliteal angle to check the hamstring tightness is there or not, silver skewer test we have to do to check the TA tightness is there or not, FILF we have to do to check the adductor spasticity is there or not, and also we have to check the rectus spasticity by Duncan Ellis. After that we have to check if any flexion deformity is there or not in hip, and then we should go for the hip control and the trunk control. If that power is good, then we should go for surgery. Before that we should go for the non-surgical method, because the age is very important for our decision making for surgery. Otherwise unnecessary irrational surgeries will not value. Okay, then we should go I should go through joint lower limb, like if hip only we will touch the adductor muscle when it will hamper the hygiene matter. Okay, and only it is for the GMCS 4 or 5, and also sometimes cesarean gait is there, we should go for the percutaneous adductor tenotomy. And the knee, there will be knee flexion deformity, some guidelines are there, like when we will go for the medial hamstring lengthening, we will go for the semitendinous transfer to adductor tubercle, semimembranous the fractional lengthening. Along with that, if the patient age is more, we should go for the distal femoral extension osteotomy. That's a very simple procedure we can do. And along the foot, when the hemiplegic patient is coming, there's some twist is there, like in hemiplegia or diplegia. Sometimes we are seeing some equinus gait patient. So if in hemiplegia one side is involved, equinus foot is there, TA tightness is there basically, then we will go for the jet lengthening. So whether we will go for jet lengthening zone 1, zone 2, zone 3, like zone 3 is always jet lengthening, only we are touching the tendon. When the same patient is coming with diplegia, bilateral equinus gait is there, then we should not touch the tendon, because we will encounter the soleus part. That will break the plantar flexion knee extension coupling. Patient is coming with us with equinus gait, but it will jump into crouch gait. That will hamper our rehabilitation main purpose. Main purpose of our surgery is make the foot plantigrade, and we can use the brace, and we can prevent the further deformity. And sometimes it will come like equinovarus foot is there, like varus component will be there, like tibialis posterior will be spastic. Then we can go for the tendon transfer. That also some principle are there. I will not go to that part. And sometimes equinovalgus is there, planovalgoid foot is there. That is the lower limb surgery. In upper limb, patient is coming with the ponated hand. There we can go for the ponator rerouting surgeries and at all.
Okay, thank you.
I want to add something. Before going to surgery, we should try Botox with splinting, and if there is stretching of the muscles, if we get good result, then we should not go for surgery.
Actually, the CP is human lesson, sir. That is a main ball game between the spasticity and the contracture. When the contracture is development, that time we will go for surgery. Otherwise, first stretching, then continuous stretching, and some POP cast, then manual block. It fails, then we should go for surgery.
And even the dynamic variety, whether that is
also dynamic variety also we have to keep in mind surgery.
And plaster can give you a better result. I can give you sometimes normally the plaster casting can give the much better result than what you can anticipate.
Okay. Next question is to ma'am. Is HIA and CP same thing?
CP can be caused by HI. So hypoxic ischemic encephalopathy is one of the causes of CP. But all HI will not lead to CP. So
Okay.
that's the basic thing.
Okay, ma'am. Thank you. Next question is to ma'am also.
Common, yes, yeah, running out of
Convulsion,
time.
yeah.
Again, this is a big area. First of all, convulsions are very common in CP, about 10 to 20% in various reported cases. And if HI is the cause for CP, then chances of convulsion is more. Genetic disorders, convulsions are more. Types of convulsions are very different. So it also depends on whether it's a generalized focal convulsions or mixture, or it is epileptic encephalopathy. So depending on that, we initiate obviously drug therapy, and drug therapy we build up on, the groups of drugs, valproate,
Yeah.
topiramate, etc. So that's pharmacology. We sometimes go into polytherapy and lowest possible number of drugs and best effect. Otherwise, you will have drug-drug interactions. Resistant ones, we might consider surgery like corpus callosotomy if there is a focal situation to remove that. These are very rare cases for resistant. In between, we have the ketogenic diet. But this is again theoretical. You'll have when I have tried to institute ketogenic diet for my CP patients, where I have failed with polypharmacology, still the child is having convulsions, I found that there are very few dietitians who actually practice a ketogenic diet. So I have attended CMEs and I have found that ketogenic diet can be tailor-made to the patient. And in Africa, actually, even in very low socio-economic conditions, they initiate the ketogenic diet using vegetable protein. So we have a couple of patients on ketogenic diet, and it actually works. But reality is we don't find many people doing it.
Yeah, in India, if the child is not taking rice, then he will not grow properly.
Yes, and to convince the mother, it's very difficult. So not only that, the mother might be convinced, but you have to, the calorie benefit and what you add to the diet and how you vary the diet is very important. Otherwise, you will put the child into another kind of nutritional failure, or may initiate more convulsions. So we have to be very careful about that. But it does work, and we have tried it on a few patients. And polypharmacology is very common. People put in drugs left, right, and center, not understanding drug-drug interactions. And another very important point, people like dystonic posturing, staring episodes, they consider that to be convulsion when it is not a convulsion. So again, convulsions get overdiagnosed, and in some cases, convulsions get underdiagnosed too. So that is very important.
Okay, thank you, ma'am. Next question is to Dr. Shurab. What are the chances of bowel bladder involvement in CP?
Actually, bowel bladder involvement in CP, we can see a lot of patients coming. They are having bowel bladder dysfunction, but CP does not actually cause the bowel bladder dysfunction. Basically, 7 to 80% patient diagnosed with CP, they are generating urinary continence later than the normal child. Okay. Some studies said that there are some correlation between that bladder continence with the intellectual disability, with cognitive impairment. Recently, some studies were done with the bowel bladder dysfunction in CP, they are seeing or not. They are saying that in GMFCS 1 and 2, by the 5 years of age, the patient are getting that continence. Basically, that neurological some problem will be there. That will decrease the muscle tone, muscle control, and some gut mobility will also be decreased, and there will be less peristalsis. That is causing constipation at all. And so, though it is not directly associated with the CP, but in CP patient, we are seeing that bowel bladder dysfunction.
Okay. Next question is to sir. Which rehabilitation technique like task-oriented training or CIMT or hydrotherapy shows the strongest evidence today?
Bobath and Bordza technique is totally depends on task-oriented rehabilitation technique. This is the most effective treatment, but in case of hemiplegia, we can go for constant induced treatment, CIMT also. Hydrotherapy and horse riding, it is effective recently it is telling that the swimming and horse riding, toy horse riding, it is very effective for child in school going child. So these are the technique we can use for better treatment.
Okay, thank you, sir. Next question is to Dr. S. Chakraborty, sir. What emerging technologies show the most promise in CP?
Okay, the technologies are emerging, so I do not know how many parts of India it has adapted. But robotic has a role. Definitely, robotic has a role, especially in the gait trainings part. If the CP child is putting on the robotics under robotic supervision, you can expect much better gait training outcome. And VR is also just developing, and virtual reality is really helping for the child to just get child's attention, fairly cognitive impaired child to. And neuromodulations now coming in the eastern part of India as well as pan India, and they are being the very much promising, especially transcranial electric stimulation and direct cranial DC current stimulation. And also the functional electric stimulation is also helping lots of things, especially.
Okay. Thank you.
Continue or should close?
Yeah.
Our time is up. So thank you, our panelists, and thank you, audience, for your concentration. Thank you.
Thank you so much for an enthralling discussion going from the etiology, diagnosis, medical management, rehab management, conventional, interventional, surgical, and to latest development.